अहिले स्क्रिन देखिरहेछ है?
Yes, sir.
Okay, okay. So okay, so color if increase hematocrit with no improvement will give colors. If decrease hematocrit with no improvement will give blood transfusion. And if patient is in shock, will give oxygen. Then will manage bleeding and fluid overload, and proper monitoring throughout the treatment is necessary. Okay, so this is the chart showing the different parameters. So in febrile phase, there is fever, and then once critical phases sets in, the fever usually decreases, right? And then potential clinical issues. Initial in the febrile phase, there's nausea, vomiting, so there is risk of dehydration. Okay, and the critical phase, there is severe capillary leak, so there's risk of shock, and there's also mild DIC and thrombocytopenia, so there is risk of bleeding also, right? And there is also risk of severe organ impairment in the critical phase. And then in the recovery phase, there is reabsorption, so there is risk of fluid overload if we don't decrease the fluid. Okay, so recovery phase ma fluid decrease garnu pani is equally important. And then in laboratory, initially the hematocrit, uh, sorry, this is the hematocrit. Dotted lines is the hematocrit. So hematocrit will be increased in critical phase, and then again decrease in the recovery phase. Platelets will decrease in the critical phase and again improve in the recovery phase. Okay, and this serological parameters, in the febrile phase there is viremia, right? So the NS1 positivity is seen mainly in the febrile phase. Actually viremia decrease by percent, and then there's antibody levels are increased. So actually viremia come by percent, then IgM IgG is seen, and IgM is IgM persists for few months, 2 to 3 months. IgG persists for life, and gives protection against the particular serotype. So the prognosis, it's self-limiting. Mortality, but mortality in severe dengue. Severe dengue mortality can be high as 20 to 30% if untreated. But by doing early recognition, careful monitoring, and treatment, we can reduce case fatality to less than 1%. Okay. So symptoms, early recognition, dengue early recognition garnu paryo. We have to monitor for the complications, keep monitoring vitals, keep assessing for thrombocytopenia and organ impairment, and then treat. Main treatment mainly we don't use any antivirals, right? Dengue virus manically medicines, but that is not needed. Most of the times, all we need is proper vitals monitoring and fluid management, right? There is a case ma khali frequent monitoring or fluid management that will suffice. Okay. Okay, prevention is the same for any mosquito-borne disease. So mosquito bites or prevent garnu paryo. And this shellfish called mesocyclops is known to feed on the larva of Aedes aegypti. So if they are kept in a pond, that may help. And then prevention of water stagnation and coverage of stored water. So rainwater को collection में breed गर्छ. So कतै पनि पानी जम्न दिनु भएन, हैन? रोडहरुमा पानी जम्न दिनु भएन, छतमा पानी जम्न दिनु भएन, बकेटमा पानी राखिरहेछ, यो ट्याङ्कीहरुमा पानी राखिरहेछ भनेदेखि that should be proper covered so that मस्किटोले आएर एग lay नगरोस्, हैन? So त्यो सब मेजर्सहरु गर्नुपर्छ. And then vaccine has not yet come for regular use, हैन? It's all still in the experimental stage one, right? So these are the preventive measures. Now let's talk about Kala-Azar. So also called leishmaniasis. Dengue ma ke question cha? Okay, पछि सोध्दा पनि हुन्छ. But now talking about Kala-Azar, there are 3 clinical forms: visceral leishmaniasis, cutaneous leishmaniasis, or mucocutaneous leishmaniasis. Okay, that's caused by parasite Leishmania donovani, and it's transmitted by bite of female sandfly, right? Female sandfly, which is called the phlebotomos. Okay, so this is the life cycle of leishmaniasis. So initially, sandfly, the infected sandfly bites the person, then it injects the promastigotes, right? Promastigotes are injected, and the injected promastigotes are phagocytosed by macrophages. And then inside the macrophages, the promastigote transfers to amastigotes. And the amastigotes multiply in the cells, including macrophages of various tissues. Okay, so the disease causing form is the amastigote, right? जुन मस्किटोले ट्रान्समिट गर्ने भनेको प्रोमास्टिगोट, it transforms to amastigote, and the disease causing form is the amastigote. And when the sandfly takes blood meal from the infected person, then it ingests the macrophages also, which has amastigotes inside the macrophages. And then त्यसपछि the amastigote transforms into promastigote, stays in the midgut of the sandfly, right? And it divides in the midgut and migrates to the proboscis. And then again, so proboscis battery is when the sandfly bites another non-infective microbe. Again, the same cycle repeats. Okay, so amastigote is the disease-causing form. Promastigote is the form which is transmitted by the sandfly. Excellent. Now, clinical features: incubation period of 3 to 8 months. So it's quite long incubation period, 3 to 8 months. So हामीले एन्ड अब के लिस्टमाइनेसिस इन्डेमिक एरियामा बसिरहेछ भने ठिक छ, ट्राभल हिस्ट्री सोद्धाखेरि पास्ट 1 इयरकै ट्राभल हिस्ट्री सोध्नु पर्यो होइन, बिकज इन्क्युबेसन क्यान बी एज लङ एज 8 months. It begins insidiously and runs a chronic course. Okay? And there is high grade fever, there is weight loss, and splenohepatomegaly. Huge form and non-tender spleen. It's called splenohepatomegaly because the splenomegaly is more prominent than hepatomegaly. Spleen is much more enlarged than liver in Kalazar. And there is hyperpigmentation, skin pigmented dark, then that's why the name is Kalazar. And there is petechiae, epistaxis, and gum bleeds. So why this happens? This there is thrombocytopenia, right? Or there is pancytopenia actually, right? So petechiae, epistaxis, and gum bleeds due to decreased platelets. There is secondary infections because of decreased cell-mediated immunity. Right? Leukocyte count and decrease on cell-mediated immunity is decreased. So there is secondary infections with other organisms, and there may be pedal edema due to hypoproteinemia. Serum blood protein level decrease also, so there may be pedal edema. Okay, so incubation period 3 to 8 months, chronic disease, high grade fever, weight loss, splenohepatomegaly, hyperpigmentation, and then clinical features of thrombocytopenia and leukopenia and pedal edema. Okay, so this is the splenohepatomegaly. So यसमा मार्क गरेको छ, so spleen चाहिँ यहाँसम्म enlarge भएको छ यसरी हैन, massive splenomegaly, and liver is also enlarged to some degree, right? But spleen is more enlarged. So investigations you'll get pancytopenia. So there will be decrease in hemoglobin, decrease in total leukocyte count, and decrease in platelet counts. There's mild increase in liver enzymes, right? And there is reversal of AG ratio. Albumin decrease also, but globulin increase भएको हुन्छ. Usually albumin is more than globulin, but Kalazarma albumin चाहिँ decrease भएर globulin increase हुन्छ. So globulin may be more than albumin. That's called reversal of AG ratio, right? And definitive diagnosis. So definite diagnosis गर्नलाई हामीले organism detect गर्नु पर्यो. Organism भनेको amastigote is the disease causing type. Then so they can be detected. Invasive methods are used. Either we have to do bone marrow aspiration or biopsy. So bone marrow aspiration biopsy गर्दाखेरि त्यसमै amastigote देखियो भने, या lymph node aspiration या biopsy गर्दाखेरि त्यसमै amastigotes देखियो भने, या liver biopsy मा देखियो भने, या splenic aspirate मा देखियो भने, right? So these are all invasive measures. Liver biopsy and spleen aspirates are rarely used. एकदम difficult cases are maybe, but bone marrow aspiration, yeah, lymph node aspiration that is confirmed, right? Or you can do PCR from tissue sample or blood. Blood, yeah, tissue biopsy aspiration गर्ने sample PCR and then there is anti-K39 antibody. So that is detected by immunochromatography or ELISA, and it decreases after successful therapy and increases during relapse. Right? So this is a very good test, NTK39. त्यसमा धेरै इन्भेजिभ हुनु परेन, ब्लडमै डिटेक्ट गर्ने भयो हैन, ब्लड निकाले पुग्यो, and then it's done by immunochromatographी or ELISA, and it decreases after successful therapy भनेको past infectionहरु will not affect this test हैन, actually ट्रिटमेन्ट गरिसकेपछि यो डिक्रिज भएर जान्छ, फेरि रिल्याक्स भयो भने फेरि इन्क्रिज हुन्छ. सो दिस इज भेरी हेल्पफुल टेस्ट है, NTK39 एन्टिबडी, इट्स अल्सो कल्ड RK39 टेस्ट right? Okay, now let's come to the treatment. So treatment, the first line is sodium stevogluconate. Right? It's very effective, 20 milligram per kg per day, intramuscular or intravenous for 28 days. But problem is there is resistance in many. If there is no resistance, sodium stevogluconate is quite effective. But there are areas where resistance देखिसकेको छ, so many places सीधे amphotericin B use गर्छ. So amphotericin B 1 milligram per kg IV, alternate days for 20 days. Alternate day भने एक दिन दिने एक दिन नदिने. Okay. So amphotericin B, but the problem with amphotericin B is its toxicity. So amphotericin B is can cause hypokalemia and nephrotoxicity. Right? So they have developed this liposomal amphotericin B. It's also given as 1 milligram per kg per day for only 5 days. So that's less toxic. No? So mostly endemic areas or sodium stevogluconate resistance, so they use liposomal amphotericin B. The disadvantage of liposomal amphotericin B is its cost. Regular amphotericin B liposomal only costly also, but it has less side effects and it can be given for less days. So hospital stay decrease 5 days. Okay. So, but the sub is parenteral IV IM. So there's another drug, multifosin. It's the only oral drug, and it can be given 2.5 milligram per kg per day for 28 days. So oral drug you then like admission right? And there are other drugs, pentamidine and paramomycin. These are less used, but they are also mostly given as parenteral. Right? So as the first line is sodium stevogluconate, but yes, so the preferred one is amphotericin B. The amphotericin B is more toxic, so the preferred one is liposomal amphotericin B, and we have this oral drug multifosin. Okay, and the other less used drugs are pentamidine and paramomycin. But along with that, along with this, we also have to give nutritious diet. And a chronic disease over there, months or patient affect by the insidious onset. So nutritional status deteriorate by answer. So you have to give nutritious diet and correction of deficiencies. Various vitamin deficiencies, mineral deficiencies, you have to correct those deficiencies. And treatment of secondary infections. Because cell-mediated immunity is decreased, whereas other secondary infections may be there, we have to treat those infections also. And packed RBCs and platelet transfusions if severe anemia or thrombocytopenia. Okay. So hemoglobin very low, packed cells and then thrombocytopenia, platelet transfusion. Then we have to monitor fever, spleen size, complete blood count, albumin, and body weight. Your subsidies are monitoring because as recovery fever decrease spleen size decrease and cytopenia improve albumin level increase and body weight improve right? And we have to follow up for at least 6 months because there can be relapses, so we have to watch for relapses, follow up for at least 6 months. Okay, so now let's come to post-Kala-Azar dermal leishmaniasis. So it develops it's a skin manifestation which develops 1 to 10 years after visceral leishmaniasis. There is this hypopigmented maculopapular or nodular skin है hypopigmented macular यसमा सो यहाँनिर देख्न सकिन्छ सो hypopigmented एरियाजहरु सिमिलरली यसमा पनि अलि nodular hypopigmented एरियाजहरु छ हैन so hypopigmented maculopapular or nodular skin lesions it may persist up to 20 years right and these people with PKDL are chronic reservoir of infections right? So they are chronic reservoir of infections so organism the lesions are भइरहेको हुन्छ so how do we prevent Kala-azar? We have to control vector again sandfly को bite बाट prevent गर्नु पर्यो insecticides हरु bed nets हरु and then effective treatment of patients and PKDL right? So transmission control गर्नलाई disease भएको patient हरुको proper treatment गर्नु पर्यो ठीक छ Okay, that's all. So Kala-azar could be very silent. Any questions? केही सोध्नु छ केही नबुझेको छ
No, sir.
छैन okay okay thank you then केही question छैन भने I'll end this meeting right
Thank you, sir. Happy Dasai, sir.
Happy